Okay. So this was a patient who had had an endonasal DCR done twice. Once for draining the pus, and second time the routine DCR was done as per the patient. So when I opened up,
just close the small window so you'll get a bigger window. Those small ones.
No, this is not running in.
Oh, okay, okay. Fine. Yeah. Sorry. Go ahead.
So when I did a DCR, it was like as if I was doing a routine case. You know, it was like very virgin. So that was it. So it was like, you know, it was as good as nothing being done. And when the sac was completely, you know, inflamed and sent for biopsy, and that is what it came as. Now the next slide. So what we learned from this is get yourself trained if you want to do an endonasal DCR well. If not, do a very good external DCR. Now, good external DCR here, what I mean to say is at least 5 millimeters from the common canalicular area should be free of any obstruction. So this was at another patient who had had, as per the discharge summary, had a DCT done. Now what happened? Same thing. I could see the entire sac there. The sac was still intact, and I could do a perfect external DCR in this patient. Now this was another patient who presented with, you can see that there is a fistula kind of a thing here. It was an opening, and through this I could see the sac, and it was filled with ointment. And when I went ahead, what I did was I just saw it was I did a complete DCT here. So what probably would have happened is they have removed one wall of the sac and the other wall was still intact. So an complete DCT was done. The fistulectomy also, I did removed the fistula, and the common canaliculus area was cauterized, and here I'm just removing and refreshing the edges of the fistula and sutured. So doing a good complete DCT when indicated is important. So this patient had had his DCT done, complaint of tearing, and he wanted the tearing to be reduced. Sorry, a lady patient. And so what I did was removed all the tissues around the common canalicular area. This was not the sac, but it was just a fibrotic tissue around that. A complete removal of the fibrotic tissue was done. And the common canalicular area was, a sharp dissection was done around the common canaliculus and the obstruction removed. A mitomycin C was applied, and a very large ostium and a large sac flap is created here. A large nasal mucosal flaps, A large flap here is important because you are bringing the nasal mucosa all the way up to the common canaliculus. You need to do that. And a routine intubation is done. And here, when you're anchoring the nasal mucosal flap, this has to be anchored to the tissue above the common canalicular area. And 3 such broad bites are taken. So this was one study we did 15 such cases with a follow-up period of 1 year. And anatomical and physiological success was seen in 14 patients, with 1 patient had a partial regurgitation with a small ostium. This was probably because he had had a repeat procedures done before, and this is due for publication in the Korean journal. Now this patient had had her DCR done, and if you can see here, the ostium is way higher up. It's supposed to be somewhere here, it's higher up and it is occluded. So what is different in this DCR is an incision is made along the same scar area, and there could be a lot of bleeding, and you can encounter a lot of fibrosis. And this is one place where probably I would use a lot of cautery. adequate cautery I mean. And you have to go in anterior to the already made ostium, the old ostium which is there, and extend the ostium along. So it's not actually impossible to make a good DCR in these in such scenarios. And I will show you something here. This is the kind of movement which probably should not be done. Okay, I had to skip that. Okay. And inflate the residual sac. Sometimes residual sac you can actually inflate and make a sac flap as well. A sac flap is made, and similarly a nasal mucosal flap is also made. So what probably happened here was, you can see this agar nasi air cells are there. These are much more anteriorly placed. Sometimes they get confused that the agar nasi air cells, and when you go into the ethmoid sinus, they probably sometimes would think that that is a nasal mucosa. Actually, nasal mucosa will not be so thin. And a large, so you can see that those are the agar nasi air cell bones that I am taking out, which are thin and anteriorly placed. And a sac flap and similar routine DCR is after that is performed, like, you know. And what I wanted to show here was, it is patent. And when you're anchoring, this is the technique that I follow, is doing a single square knot. Now, why single square knot is because it is easy to remove in the OPD. So you can actually just rotate it. The knot is rotated from the one of the punctum and removed. Now, what about a patient like this who comes with traumatic lid laceration repair done? So when you see a laceration of this kind and you see the canaliculus is torn, feel free to redo the procedure. A mini Monaco stent is passed. And you can see this, it's not very clear maybe, a pale cuff is there in the pink background. So that would be the other cut end of the canaliculus. So a mini Monaco stent is placed and a pericanalicular stitch is taken and closed. Now, what about a traumatic DCR? This patient had had repeated pain and swelling. So this was the patient who had had his open reduction and internal fixation done for his fracture elsewhere with a secondary nasolacrimal duct obstruction. So even here, the it can be slightly bloody with fibrotic tissues. The only difference that I find here when I'm doing a DCR in these patients are the bone can be relatively thicker, is because of the trauma that they've had, the fracture that they've had there, and the remodeling of the bone that has happened. So otherwise, it is not a, it's relatively straightforward. So you can make a nice big large flap, the sac flap, and the nasal mucosal flap is done, bicanalicular intubation placed, and the wound closed. So what we learnt in this is, when you're imaging a patient after the trauma, and if there is a bony nasolacrimal duct fracture, it would probably be a good idea to do a primary intubation itself. So this probably, in the interest of time, I would skip Savri.
Go ahead.
This is a conjunctivochalasis patient. Now, what I was doing in the earlier stage, they usually come with surface irregularities and tearing sometimes. So this was in my earlier stage, wherein I would block, giving a subconjunctival block, and then so what happens, that chalasis is completely lost. You don't know where it is. And you can see that I'm lifting up the conjunctiva and then cauterizing. I'm using the fulguration here. But what happens here is, when you're lifting the conjunctiva, the basic pathology in conjunctivochalasis is not just the conjunctiva, but it is also the anterior tenons underneath. So when I did that, you can see that there is some residual chelasis here. So this was the pre-op and this is the post-op. You can see a small tear film is made, but it isn't sufficient. So then later what we started doing was under topical. So when you're doing it under topical, you can actually see that the conjunctiva is shrinking, and 1 or 2 rounds of rows of such is given, and you can see that there is a complete resolution of the chelasis. So this was something, and any pouting punctum is not pouting punctum, or if there is a swelling medial to the punctum is not a chalazion, it can be a canaliculitis. Now this was something that I saw recently in my just last OT, a routine DCR, and I saw this mass between the nasal mucosa and the bone. I really don't know what it is. I've sent for pathology. Let's wait and see what. I just used the crescent and shaved it, and I've sent it for biopsy, waiting for the report. Thank you.
Thanks, Shruti. Now that was a real video course. I think it's very hard to suddenly video, especially these kind of variations when you're doing intraop. So in whatever way you can capture it, I think that's amazing, and that was really a wide range of small little points which you do come up when you're doing, and DCR is so common that these are really good tips and to know when you're encountering.